David, the way I thought we would structure today's webinar is that we'll ask you to make some initial comments and set the stage for the ensuing discussion. We're already getting some excellent questions from some of the participants. So with no further ado, take it away. And we look forward to having a great chat on this very important topic today. Dave Snadden.
Thanks very much, Randy, and thanks everybody for joining us today on, I don't know what it's like where you are. I'm in Prince George. It's a beautiful late winter day here. Spring feels as if it's coming, which lifts everybody's spirits. I thought I'd give you just a very brief introduction. I'm pleased so many of you have decided to give some time today. And I'd really like to hear your questions and have a conversation with you. But I might need to paint for you a little bit of context, and you know, you might be wondering what on earth does the Rural Doctors UBC chair actually do. So to give you a little bit of background, this is the first rural academic chair created in Canada. It's created by an endowment from the rural physicians, and the purpose of the chair was to provide a UBC appointment in order to both advocate for healthcare and to also develop research capacity which was relevant to rural areas. So since I came into the chair a couple of years ago, that's what I've been doing, is trying to stimulate some small projects around our rural healthcare workers, which are relevant to rural areas. And I've been engaged in some of my own research, which has been about generational change in family medicine in rural areas. And also we've been looking at health system transformation in Northern British Columbia. The organizations that I work with are the Department of Family Practice at UBC. I'm part of that department. I work very closely with the Rural Coordination Centre, British Columbia. That is a group which was established through the Joint Standing Committee on Rural Affairs. The Joint Standing Committee is a collaboration between the Doctors of BC and the Ministry of Health, which provide supports for rural physicians and healthcare workers. And the Rural Coordination Centre takes on a number of projects from them to try and support and enhance rural healthcare. So that's just a little bit of the background of what I do and how it came about. When I'm thinking about things that I'm interested in, what I see in the landscape, and I do think we're at a time of change, access to healthcare is a big issue. I can see changes beginning to come around access for rural populations based around developments in telehealth, particularly relationship-based telehealth. I personally am concerned when medicine is not delivered with relationships. I think the other thing that's always been an interest for me, and some of the evidence is that you're more likely to get health professionals and work in rural areas if they come from them, is how we persuade more people to apply for healthcare careers from rural areas, and how we find better ways of supporting them getting into our universities and colleges. The other thing that we're beginning to see is a change in the generational aspirations of new healthcare workers, particularly physicians coming through. And that's leading to some innovations around, you know, clinic funding and how things like that work. And the other two things which I think are important are how we continue, in my view, to support generalism. In other words, how do we train our residents and young physicians better to be good, all-rounded rural physicians? And I think cultural safety is a really important topic at the moment, and the relationship of the health system to our Indigenous communities is another important one. And cultural safety, I think we need still collectively to do a lot of work on. So that's just a few of the things which have been bubbling around in my mind over the last few months. And Randy, I'd be very interested in your thoughts and on hearing some questions or any clarification of any of those areas.
Sure. Okay, David. Let me start out perhaps by putting a couple of questions that have come in so far from our audience, if you're up for that. The first question is related to the situation in particular in northern BC. This participant writes, medical evacuation is always a problem in the north. Thoughts or any examples of innovation in this area regarding how to address this issue?
Thank you very much for that question. And you're absolutely correct. This is a major issue within all rural areas in British Columbia, not just in British Columbia, but in Canada. There are different systems. And I'm certainly aware at the moment of a lot of work going on through the Rural Coordination Centre British Columbia, which has commissioned a study on effective ways of transport. They're working with the BC Emergency Services and with government to try and see if we can find some solutions to the problems that rural patients are facing. Now, in my time here, I visited a lot of rural communities, and I've spoken to the physicians and to the mayors and other people in them. And one of the things that the Rural Coordination Centre is doing is visiting all the rural communities to speak to them over a 3-year period. And transport comes up as a major issue, not just emergency transport, but think about Greyhound not being there anymore, and how people get to routine appointments, or how relatives get to see people who are in hospital. From my own perspective, I think when I look at the transport issue, we do have, I think, within British Columbia, probably the resources to evacuate people are maybe not as good as they could be. Certainly, I know that rural physicians do often spend a lot of time hanging on and waiting for someone to come. Sometimes other priorities get in the way, and sometimes, as you all know, the weather gets in the way. There are some really interesting innovations, because one of the solutions to the transport problem that I'm beginning to see, or the transport issue, is to transport less. And I think if we can support our rural healthcare workers better when they're in a difficult situation, the transport decisions may become more effective and efficient. And I'll give you an example of the kind of innovations. There's currently a pilot project going on which connects rural physicians to critical care physicians using an app on their iPhone. And that means that a physician in an emergency room with a very difficult problem can actually get help within minutes, to have somebody there who's got extra skills that can help them through. And I think those kind of innovations may be as much part of trying to solve the acute transport problem as, everyone thinks, well, let's have more planes, let's have more helicopters. There may be other solutions which will work very well in rural areas. And if we can find a way of testing these better and investing in them, I think we may get some very good outcomes from them. I'm not saying that people will no longer need to be transported. There will always be that need. But it would be, if we could handle some of them without the need to transport, and if we can give confidence and support to the physicians and nurses looking after them, that may go some way towards helping this problem.
So, David, Robert Newell, who's one of our participants, writes further to this question of technology and its role in helping with this issue, wonders or says, how many specialists have, as far as you know, opted into telehealth? And is payment some sort of obstacle towards their participation?
I thank you very much for that question. And I think what I'm seeing is a lot of specialists now getting involved with telehealth, and the payment issue, although it was a problem, is clearly being resolved. So they are now being paid for these consultations. I'm aware of links between family physicians into remote communities and First Nations communities using telehealth. These are family physicians who visit these communities, so they have relationships with them. They visit on a regular basis, but then they will continue to provide support for nurses in the community and see patients by telehealth. And if necessary, they will bring specialists into that consultation remotely. I'm certainly aware in Northern BC of some patients who have been referred to specialists in the Lower Mainland, and their first consultation and maybe follow-up consultation is by telehealth. The facilities are now there. It's now a growing facility. And one of the things that worries me about it is that we're beginning to see commercial organizations now beginning to provide telehealth. And I'm much more concerned that it's provided on a relationship basis. So all of you around this webinar will understand the importance of having a relationship with your primary care provider. And I think if telehealth can be used to enhance that relationship as opposed to a substitute for that relationship, then I think that to me would be the way to go in the future.
Okay, further to the question of money, David Dirksen poses this question: with the monetization of our whole society, how do we get doctors into the field without the debilitating debt that seems to accompany them through their career in medical school?
Well, that's a huge problem, I think, for graduates coming out of medicine, particularly those that come from less privileged backgrounds, where they may actually build up quite big debts. I did notice that recently the BC government waived interest payments on student loans. I thought that was an important step. And, you know, the other thing is that, you know, I talked about the Joint Standing Committee earlier. One of the things they do is to provide incentives and support and for residents that become physicians coming into rural areas. So they do get some support to get loan repayments and to get some funding to offset some of their loans when they come into communities for the first time. So there are some mitigating factors available, but I still think it is a disincentive for people coming into health careers, particularly from rural backgrounds. And it'd be lovely to see more, more grant aid for rural students, so that trying to come into a health career becomes less of a financial barrier. And certainly in the Northern Medical Program, the communities, the inception of the program came together to provide an endowment called the Northern Medical Programs Trust. The board of the trust is actually made up of people from the communities, mayors and councillors, and they support students in the healthcare professions in the north who are learning with grants to offset some of their expenses, and with travel expenses to get to different learning opportunities in rural areas. So there is some funding there, but it would be nice to find ways of increasing that.
Okay, thanks for that, Dave. Kate O'Keefe writes, there is and has been lots of talk of the team approach, but it is slow in coming. In the West Kootenays and in Caslow, where Kate lives, we have a small team, but it doesn't access major specialists. How do you see this rolling out? She goes on.
I think the future of primary care is going to be team-based. What I I hear from young physicians is they want to work in teams, they want to work under different remuneration models. And, so they want to work with nurse practitioners, with pharmacists, with occupational and physiotherapists and social workers. And certainly with the primary care networks, which are beginning to develop in British Columbia, team-based care is an important component of that. And in my work in the North, we've been researching Northern Health's primary care system reform, which has been going on for several years. And that is team-based. That is trying to create primary care teams that are linked to a family medicine practice. So there has been some movement in that area. The problems, and I think the questioner alludes to this, is that teams don't always, that they suffer from what we all suffer from in rural areas, and that's poor recruitment and trying to get enough of the right people. And so as team-based care develops more in rural areas, and I would say that most rural communities I've gone to, they all work in teams anyway out of necessity. So the doctors do work with the local pharmacists, and it might not be officially designated as a team, but that's how they work. But the teams may just not have all the people in them that you would necessarily like. So each rural team tends to be a little bit different. And I don't know what the solution for that is other than trying to develop better recruitment and retention supports for these areas. And in terms of specialists, the only way, teams will connect with specialists when necessary. And I think for rural areas, specialists will be people who come occasionally or who come through telehealth or who are connected to a patient through their primary care teams. They're a resource a team will go to when needed rather than to be intrinsically part of the team.
So further to that, David, you and I recently attended a health participants retreat, partners retreat in Vancouver. And for the first time, I, as a layperson, was introduced to the, not concept, the actuality of primary care networks. And I came away with the understanding that these primary care networks, which are very much team-centric as I understand it, are going to become the actual new structure for the delivery of healthcare across the province, and certainly in rural BC. How do you see these PCNs slotting into small, remote, rural communities that face some of these kinds of issues that Kate and others have raised today?
So I'm terribly sort of aware of the fine detail of the primary care networks, but in my understanding, and so that this has been a development that's come through the Ministry of Health and through the GP Services Committee of the Doctors of BC to support primary care right across the province. In the rural areas, what we're seeing is that the networks are developing with the family physicians in different areas, combining as a network and then linking with the teams established in those areas through the health authorities. Now, my main experience is in looking at the system reforms in Northern Health, because we've been researching it. And in some ways, what's happened there is very like what I think the primary care networks will look like. And I think each network will be subtly different. So what's happened in Northern Health through the divisions of BC and with Northern Health Authority is they've come together to create priorities and visions about what their various community networks would look like, and to try and find ways for the physicians and the other healthcare workers to work together in teams for the benefit of their patients. There's a very patient-centered development. Now, you'll appreciate to get from where we are in the system to there does take a long time. The Northern Health reforms have really been going since about 2012, and it takes a lot of work to change people's jobs around and to build new cultures and to find different ways of communicating. In some interviews I was doing recently, some of my respondents I was asking them for patient stories. I said, have patients benefited from this? And the answer was yes. That they gave me some examples of where your primary care team members had gone into a local hospital and to work with the hospital-based team members with the patient to prepare for a patient with very complex problems coming home. And the patient now appears to be better than they were 4 or 5 years, within the last 4 or 5 years, because they've got supports they didn't have before. So I think there are some real advantages in where the system is going. I just think it's going to take quite a lot of work and quite a lot of relationship building to get there.
Okay, fair enough. Here's a question. I'm not sure you can really say much more than you already said to that earlier question regarding the transportation issue in northern BC. But Cheryl Jensen writes quite simply, the BC EHS Community Paramedic Program. Any thoughts or comments?
Yes. And again, people around the screen may have more information about this than me. But we see the paramedics in rural areas very much as part of the team. And I know that BC Emergency Service have been working with rural areas to try and enhance the skills of paramedics. And with one of my colleagues I was working with in a small community had said to me, one of the problems is that, or one of the original problems was how, when you have paramedics with enhanced skills, how do you keep their skills up? And he said, it's dead easy. They could just come into our emergency room and be part of the team, and we can help them. So it's that kind of development of collaboration which will benefit all of us. And I think the paramedics in rural areas are highly skilled. They need to be highly skilled because, anything can happen. And often, a rural healthcare worker they're quite isolated, and it takes time for help and other resources to come.
Okay, and so further to that question, David Dirksen, who posed the original question about transportation issues in the North in particular, thanks you for your comments on transportation and says that, quote, I agree that in community care is not in the back of an ambulance, but in the local hospital.
Yeah.
Any comments
Correct.
on that?
Absolutely, I totally agree. And I think what we have to think about is that, every rural community is different. And not every rural community even has a hospital. Sometimes there's an emergency room, or maybe in some of our remote First Nations communities, a nursing station. And how do we prioritize the context of any event that's happening to a patient? So, if I give you an example, if somebody has a stroke in somewhere like Prince George, they will have a CT scan within 4 hours to make a decision as to whether they get whether they have a clot in their brain and they need drugs for it. If you're in a remote community that's 4.5 hours from the major road, how do you get that person to the standard of care that's expected everywhere else? And I think these are some of the challenges we need to grapple with and think about. How do we prioritize? So yes, we can support people in some things for in-community care, but there's other times we have to get them out. And I just don't think we've yet figured out the most effective and efficient way of doing that.
Okay, this is obviously a topic of terrific interest to many of our participants today. Martin Metz writes, how do you see community paramedics that are now working in about 100 rural and remote BC communities integrating with local healthcare teams? And you've already addressed that in some fashion. Any further comments on that, David?
I think that we're still at that period of, if you think, maybe if you go back, say 10 years, everybody worked in silos. And, we're in that process of beginning to try and break those down and collaborate. And teams will allow the collaboration, but we do have, certain barriers that we need to begin to remove. So, for example, Northern Health in their reforms, they spent a lot of time working collaboratively with the unions in order to change people's contracts to allow them to work across silos. And that takes a long time, but it was a really important piece of collaborative work. So those are the kind of things that we need to do. I'd also like to think that, the other barriers we have is that it's something simple like medical records. Medical records are not always electronic medical records you would think would be shared around all the people looking after somebody, but it's not how it is. And I'm certainly aware of one small community where everybody uses the same medical record. So the same medical record is used in the emergency room as by the physicians. The nurses can fill it in. And they're beginning to think, okay, so if we've got the paramedics around, I wonder how we can plug them into this as well so that we have all the care for the patient in one place as a recording. So these are some of the kind of barriers that we have to get through in order to get to more seamless care for patients.
Okay, here's a place-specific question for you. The questioner's name is just LSY, and he or she writes the following: regarding Slocan Community Health Center, located in New Denver, BC, Interior Health has posted 2 vacant family physician positions with 24/7 ER coverage. In May 2018, we found a doctor through our physician recruitment video. This doctor has been working at our health center in what appears to be locum coverage. To the best of my understanding, this doctor would like to work here and is not intimidated by the 24/7 ER. I also understand this doctor has not been offered a contract. Why not?
I'm afraid I'm totally unable to answer that question. The arrangements in different health centers and with different health authorities can be quite different. So I don't know the detail there and wouldn't begin to be able to answer that one. I'm sorry.
Sure. Well, I know that at least some folks from Interior Health registered for the webinar. So if one of you are tuning in right now and have an answer or a comment for that question, please feel free to type it in and we'll share it. Martin Metz writes, David, how do you see community? Oh no, we've already done that one. I'm sorry. Let's move on to Diana Guerin's question. You do see more of the Interior Health doctors looking at telehealth, do you not? Some small communities have an RN only health center with no doctor, as you said a moment ago, and travel is a big issue in the most remote areas of the province. So this is another question. Let's skew it a little bit. In your experience, doctors who aren't just fresh out of medical school, doctors who have considerable experience in their practice, what's your take on how amenable they are to adapting to and adopting telehealth tools and practices?
I certainly see people using telehealth right across the age spectrum of physicians. I mean, you can look at me and you know that I'm not a spring chicken. This is how I work a lot of the times, using this type of technology that we're using today. And so I think, I don't think age has got so much to do with it as availability, and depends on the pressures. We're hearing a lot about physician burnout these days, and I think support for physicians through telehealth may be an important facet of that. And I also think that the comment about, a nurse in a small community, that's a really good place for there to be telehealth arrangements to be, if there's a practice involved with that community, but is at a distance. And I'm aware, particularly in some of our Northern First Nations community, that is the arrangement. There is a telehealth room in the nursing station with a connection to physicians. But as I said before, the relationships are already there and they're important. So that means that there are a couple of things which are important behind this. One is that the technology needs to actually exist and be set up. So there needs to be an investment in technology to get it into the right place, and an investment in the relationships to allow it to work. And then the other thing is bandwidth. Is there sufficient bandwidth in terms of being able to put a telehealth system into some remote communities? And I'm certainly aware of some of the very remote communities I've been in whereby bandwidth has been an issue in some of them, and others have got excellent bandwidth which is often through microwaves rather than satellite. So there are some infrastructure issues, but I think there's a huge potential that we're just beginning to realize. And it's sporadic. Often telehealth comes into communities because somebody there really wants to make it happen or sees the advantage, and it's driven from the communities.
Right. I think Cody is a great example of the latter, right? A couple of BC physicians saw the challenge, seized the opportunity, and now we've got a smartphone-based app that really doesn't require bandwidth, but it does at least require cellular connectivity, right?
That's right. And you know, Cody is a very good example. And if those of you don't know what we're talking about, I alluded earlier to an app that brings a critical care physician to your hand, basically. That's called Cody. So physicians who have the Cody app on their phone, they just press it, and they're linked to a critical care physician very quickly. It's a classical rural innovation that was put together by enthusiasts. Those who are using it say it's just fabulous. And the interesting bit is that the confidence it gives, you know, the kind of quotes from people are, you know, because I've got my phone by my bedside when I'm on call, I sleep better because I know if something very stressful happens, I can get help if I need it. So that's the kind of supports that we need to begin to think about. But the real challenge with something like Cody is how do we then take it from its excellent first beginnings where we've got enthusiasts running with it, it has been proven to work, to that next stage of becoming supported systemically through our healthcare system. And that always seems to be quite a big gap that to try and jump over.
Right. So that brings us to, among other issues, the issue of communication. So here's a great case in point. For those of you who are interested in learning more about Cody, you can go to the BC Rural Center's website, bcruralcenter.org, click on resources, click on health, and you'll find both an article and a video that will explain a little more about Cody. Okay, Robert Newell writes, and I hope you know what these acronyms stand for, David, because I don't. Bridging courses from HCW to LPN is a problem in the Smithers area. Courses are canceled because the 20 participant level is unachievable. To travel and or live in Terrace or Prince George is not financially viable. How do we secure that course when it does not fit the NWRHD mandate? Even though with physician recruitment and retention, even though with was provided with $60,000 in 2018.
So I don't know what the ins and outs of these particular courses are, but I think you're absolutely right that bridging is important. And you know, I'm assuming this is a face-to-face course, and I'm just wondering whether there are ways of part of that course at least being developed, and it would take the college running it to do this, into something that would be more available online. And you know, I have I've got some students I work with, and these are people who are graduates who are maybe doing things like PhDs or master's degrees, and they're doing them in other bits of Canada or in other parts of the world. And all of the degree, apart from maybe 2 or 3 weekends, is online. And so I'm beginning to, I've always felt that access to education is the biggest single thing to bring rural, up to where it needs to be. If you think of the access to education for many rural people, it's really difficult. So I do think we need to be investing in more innovative ways of training our rural health professionals in environments in which they live and work. And also of trying to get more rural students prepared to get into university, and then after that to be thinking of health careers. It's a major issue in the, if you like, the ecosystem of rural areas, which I think needs a lot of work and a lot of investment.
Okay, thanks for that. Gordon Borgstrom, who happens to be the BC Rural Centre's Executive Director, asks, is Dr. Snadden aware of Roger Harris's work as the Forestry Ombudsman on the need for a rural helicopter emergency transport? Do you see the value of having something, for example, similar to the Alberta STARS system?
I am indeed aware of Roger Harris's work, and thank you for asking that question. And it's certainly one of the issues about Alberta and helicopters is it's flat, which BC is not. And I think some of the distances in BC do preclude to helicopter transport, but you're absolutely right that in evacuation like that, sometimes it would be the best way. There aren't many, and I would have to hear from anyone from BC Emergency Services what the resources are. A lot of our evacuations are by fixed wing aircraft. One of them, I think, one of the more important pieces that I took out of Richard Harris's report was his view that there was a rural-urban divide or discrimination in terms of the culture of emergency transport in British Columbia, and he was quite open with that. I mean, his report's available online if you want to go and look at it. But essentially, he was saying that in your rural people, you will get this, that in urban areas, they prioritize urban things. And if you're rural and you live out there, that's your problem. And therefore, you won't be a priority. And that's a cultural issue which he put his finger on. And I was intrigued recently to read an article from a psychotherapist who works in a very remote part, in fact, within the Arctic Circle in northern Norway. And he was describing his journey from being an urban-based Swede to working in a really, really tiny community in the Arctic. And he coined the term urban or geographical narcissism, which I thought was really very nice, because I thought his description of that encapsulated one of the issues for all rural communities, is in that we're not necessarily heard within urban areas, that urban protocols are designed around urban patients and don't fit rural, and decision-making often is based on urban priorities. And so one of the reasons my chair came into being was so that I could try and raise the issues for rural patients within the urban institutions. And that's what the Rural Coordination Centre of British Columbia is doing every day. And I think that working with groups like the Rural Centre and the Rural Health Network, which are community-based groups, I think together we can begin to get our voice heard. And I think this is not so much do we need more helicopters, we need a cultural change, I think, in how rural is viewed and in how rural is supported.
Okay, terrific. Here's a quite detailed and thoughtful set of comments from Wesley, and I'm not saying Wesley's last name, starts with CRA. Sorry about that, Wesley. He writes, my thoughts. The Trauma Association of Canada published a good paper, Trauma System Accreditation Guidelines, in June of 2011. My suggestion, I have several, but this is on topic, is to institute a new classification of a level 6 classification for small rural communities that is a hybrid of a level 5 trauma center that combines a micro-hospital with a dental clinic, physician's clinic, optical center, laboratories, mental health, rehab, all centered around a hospice and long-term care facility, all of which would be macro-sized in scope and staffed by fourth-year medical interns and teaching physicians and medical health professionals. All level 6 centers would be classified as teaching centers, thereby funded by both the BC government as well as universities and other technical and corporate institutions in a P3 relationship. What do you think?
Well, it's certainly, certainly a lovely idea. You can see the vision of how that would work. And I guess the question is, how do we get from where we are to there? And, already one of the things that I think is important is the whole concept of generalist training. We've had a lot of specialty and subspecialty training has appeared in the last decades in medicine, sometimes to the detriment of generalist training. And we already have places around the province where we are providing generalist training. We have things called longitudinal integrated clerkships, and in places like Trail and Fort St. John and Terrace, where fourth year or third year students spend the whole of their year in that small setting, working in the team and as part of it. And they are very well trained clinically because they're working with people in the hospital, with family physicians who come into the hospital, and with specialists who are there or who are visiting. And they see everything. And that, to me, has just been fabulous training for them. So we might not be as far away from that idea as one would think, given that we already have training sites across the province where we have students, residents, and family physicians training in small centres or training each other in small centres. But to get to the next classification, I think would be an interesting journey, and certainly it would raise the profile of rural in terms of evacuation. Because if you're triaging a patient, and the patient's triaged on the basis of their condition, and there's no description or there's no consideration given for the context in which it's happening, then the decisions will never be made in the favor of rural patients. And I think this level 6 idea has some merit if we could think about geographically adding a weighting to evacuation decisions, which would then prioritize patients who don't have the supports in rural areas at a higher level. So I'm not sure if that quite goes towards answering the question, but it's an interesting thought about where rural might be further down the way.
Okay, Wesley Cragg. Sorry about that, Wesley. I hope that's helpful for you and to you. Kurt Firestone, David, writes, community health centers, urgent care centers, primary care networks, all 3 programs are currently being implemented. How should a rural community go about making best use of these initiatives?
So maybe I can give you an example of what I see happening. And I was speaking recently to some of my colleagues in the Prince George Division of General Practice. And they are beginning to work, well, they're developing their primary care network in which they see the physicians working together with teams, and they're developing an urgent care center. And they see the people in the urgent care center being completely embedded in an interdisciplinary team and actually providing a resource to the community. And they see, at the moment, the out-of-hours primary care in Prince George is actually run by the physicians, and they have a walk-in type of clinic so it's the family doctors that have practices in the town that run it. And they're beginning to think whether those people may be the same people that end up in running the primary care centre, not in an attempt to integrate. I don't know whether that will happen or not, but that's some of the thinking. And the other thing that they're beginning to develop here is a family medicine unit in the hospital, in which the community-based teams will be able to go into the hospital to work with their patients in there in that unit. So the whole concept is about trying to integrate these things together so that people are working together. Now, Prince George is a big community compared to others, so the models here will be different from in the smaller communities, but I think the principles of collaboration and sharing and trying to work in a patient-centered way, in other words, what's best for the patients, are fundamental principles that could be built into any of these developments in any community.
Thanks for that, David. We talked earlier about the burden of student debt as young physicians go out into the world with enormous debt in some cases. Here's another fiscal question, also from Kurt Firestone. Fee-for-service practices mean that GPs must concentrate on their business, ensuring income levels. How do we best move that team care approach, that it takes priority while protecting individual physicians' income expectations?
So there's been quite a lot of movement in Canada away from fee-for-service over the last little while. The new generation of physicians are much more inclined to be looking for non-fee-for-service arrangements, which are called alternate payment plans. What I've seen in communities that have gone into crisis around recruitment, the docs have all left and everything, and that happens in rural communities, is that different models often appear afterwards. And they may be ones where the clinic may be owned by the health authority or by a local society, a non-profit, and where the different types of salary or blended arrangements are created with the health authority and the physicians. So we've got quite a number of small communities now where essentially the physicians are on an alternate payment plan. They're not on a fee-for-service plan. So I think there's a growing development in that area now.
Okay, here's a totally different question. Heather Smith asks, what has changed between Alberta and BC? The care is being refused for non-life-threatening procedures, i.e. cancer treatment, heart conditions, etc. Any information on that?
I don't know. I think that generally within provinces, it's the healthcare tends to the priority of the healthcare is to try and provide it within the province. But you're right that there are areas where the nearest tertiary care hospital, if you think up in the Peace or around the kind of Jasper Banff region, where the nearest hospital is in Alberta. So I'm as far as I'm aware, there are still arrangements into some of the Alberta hospitals, but I think also if it's a highly specialized service that's required, that if it's available in province, that would probably be where they'd want it to happen first.
Okay, thank you. Jessica Ray comments that in New Denver, as a response to threats of emergency services cutbacks 9 to 5 Monday through Friday, some people are talking about the possibility of the community taking back management of the healthcare center, much I would imagine as the folks on Gabriola Island did some years ago. Do you have any thoughts on that?
There are models out there, and I'm aware of another community where the health center is actually owned by the community as a non-profit, and they run it. So there are models out there. I think that, thinking about the health centre as a building and the community owning it is one thing. The challenge always is, how do you staff it, and who funds the staffing within it? And so if there are nurses in it and the health authority funds them, how does that work? And you can provide a space for physicians, and what will they be on fee-for-service or alternate payment plans? There are different ways of doing it, and so there have been successes there. But just as a warning, there's also been failures, where I am aware of one community that created a health centre, and they were never able to recruit a physician to it. There was another community not that far away where there were physicians who would have gone to it. And they then developed a commercial telehealth link within it, which didn't really work either because it wasn't relationship based. So there are risks around thinking about it, and it needs to be thought through in the details, prepared very carefully.
Okay, thanks for that. Here's a question on an aspect of rural healthcare that we've not touched on yet. Robert Newell writes, I understand the challenge in providing long-term care beds with the expected surge in need over the next few years, i.e. the graying of rural BC. Although increasing home care will work effectively in urban areas, Robert writes, in rural areas where often visiting one home in a day is an accomplishment in winter. Placing these long-term beds in small communities surrounded by rural residents, 42% of northwestern BC lives outside municipalities. Any thoughts or comments on that issue?
Yeah, I mean, you touch on a big issue, which, as you say, is going to be a problem over the next 10 or 20 years for us. I don't know the solutions here, because, if you're in long-term care, you don't really want to be that far away from family. And the long-term care facilities are very variable across the province. So I know that it's a priority for government right now. Healthy aging and how to support people in aging is an important thing. I think preventative services may be really important for us to think about. I mean, health is not just about illness, it's also about wellness, prevention, and the social determinants of health. And so there may be things we can do to mitigate against the need for long-term care by investing in other things, but long-term care facilities will need to be funded and built by somebody, and I don't know who that would be.
Okay, finally, just a couple of pieces of information, David, from our audience members. David Dirksen writes, Interior Health is using helicopters. This speaks to that question about what about the Ombudsman's report, in some of their transports through their heart high acuity response teams. So that's an interesting piece of information. And Robert Newell lets us know that the new Terrace Hospital is slated to be a trauma center.
Yes, and that would be appropriate for Terrace.
Right. So, Dr. David Snadden, we're like a Swiss watch. It is almost exactly 1 hour since we started. So I wonder if we could wrap things up with a few comments from you too, especially those members of our audience today who are lay people, who live in remote rural communities, from the north down to the US border, from the Alberta border to the magnificent Pacific Ocean. What they should be feeling about the future of healthcare in their communities, any encouragement that you might be able to give them or share with them about things that they can do generally to help their communities grapple with some of the healthcare related issues that they're currently dealing with.
I think the first thing is that don't feel alone, because there are lots of people who are interested in making rural healthcare better. From the institutions that train people, and from groups like the the Rural Coordination Centre, British Columbia, that really is working very hard to support physicians and bring different groups together to think about healthcare. I think the most important thing that I can see is that we will not be able to solve these problems within our own disciplines or within our own professions. We need to work together. And when we're advocating for change or different funding opportunities within as rural physicians, and when we're working with our various health authorities, we sometimes don't have the patient's voice with us. And I think that engaging and supporting your local health professionals is actually really important in bringing change. We will only do it together.
Okay, thank you very much, Dr. David Snadden. Ladies and gentlemen, thank you so much for joining us for today's BC Rural Centre webinar. As I said earlier during the webinar, if you have any questions and would like further information about any of the information that you heard during today's webinar, be sure and visit our website at bcruralcentre.org. Click on resources, click on help, and you'll find tons of useful information there. So on behalf of all of us here at the BC Rural Centre, I'd like to once again thank Dr. Snadden. Terrific. We'll have you on again soon, I warn you. And ladies and gentlemen, have a terrific day. Thank you.